Sohail, let me know when you're recording.
I'm recording now.
Great. Hey, welcome everyone. We wanted to welcome you to the first webinar for inFoods IBS. I am super excited to introduce you to Dr. Shaikh. I think you're going to find him an expert not only in GI but also in treating patients with IBS. And so, Dr. Shaikh, if you could take it from here, I'd appreciate it. And we're looking forward to hearing what you have to say.
Awesome. Thank you so much, Zach. Thank you, everybody at inFoods, for putting this together. It's my pleasure to talk to you today to try and help us understand another tool in our toolkit to help patients with IBS. Please feel free to send some questions to the chat box if you have it, and be happy to answer what I can at the end. So, not to belabor the point of IBS, but we'll have an introduction. We'll do some clinical review, some data review for what inFoods brings to the table, review some processes and some case studies, and then we'll do some Q&A at the end. So, as we all know, IBS is a disorder of gut-brain interaction, although there can be multiple factors at play, whether it be due to bacterial overgrowth or exocrine pancreatic insufficiency or food intolerance or other things that can exacerbate those, and we can find known entities versus unknown, where we treat them, we do a lot of things, and we can't really find out what the aegis is of the actual pathology. So this has a huge impact on patients, whether it's abdominal pain, discomfort, bloating. All of us get referrals and patients are coming in, and most of the time we can help it. PPIs, generally speaking, can help us with a large myriad of complaints, but we have those that won't really get better, and we're trying to really kind of find a specific etiology that we can help them. And patients often are reaching out for kind of like, I want that one fix and I want this. And some of them kind of, it falls a little flat, if you will, on them that, oh, just take this pill, it'll take care of it. And they're like, okay, but what's wrong with me? So this can help delineate some of those things. A lot of research has been done in this arena, and there are a lot of not just theories, but potential interventions, whether it's inflammatory markers, whether it's food and diet that you want to address, whether it's brain-gut interaction, whether it's SSRIs, NRI, non-selective serotonin reuptake inhibitors, whether you want to give antibiotics. So there's a myriad of treatment options that are out there, but to find a specific cause is always elusive. The effects of food are well known. We can have osmotic effects, chemical, mechanical, everything that's written here, whether it's psychosocial events that are triggering, or other things like fermentation and other bile acids and things of that nature. All of our patients come to us and like, doc, every time I have that hamburger from McDonald's with extra bacon, for some reason I have symptoms. Yeah, you're probably gonna have symptoms if you're doing that to your body, but they can try and eliminate some foods. Some are very easily known, like milk products and lactase deficiency. Some are lesser known, like sucrase deficiency, but we can try and tease our way through the specifics. But at the end of the day, the patients, sometimes they can't figure it out, and you're really trying to help them. Again, they're reaching for that specific cause of what may or may not be causing them to have symptoms. General dietary recommendations for IBS patients are well known. Avoid certain foods, avoid snacking, alcohol, smoking, caffeinated drinks, kombucha. There are a lot of things that we know that we can tell the patients, but even when we advise them to do these things, sometimes we can't find what it is. When we do the low FODMAP diet, there's some drawbacks to it, as are well known. It can be very, very onerous for the patient to really kind of eliminate all of them. You can do a step up or a step down approach, but still it can have some negative impacts to the patient in terms of compliance. You can give them the best advice, but you really want to tailor what you give the patient to do with the possibility of them actually executing what you're asking them to do. Oftentimes we struggle as physicians to make the patients really understand and go with us on a journey, but sometimes they just don't want to hear it. They just want, if you will, a quick fix, or sometimes they just don't want to go through the effort that you're asking them to do. The pharmaceutical options are there, and they're not bad. A lot of them are actually quite effective. But even if you have your Linzess, your Emtisa for the IBS-C, IBS-D, you have Xifaxan, Viberzi, and others, and IBS-M are mixed. There's not really something other than like maybe fiber that can really help with both, but that can exacerbate some bloating. And if you look here, I just want to highlight the treatment response versus placebo response. And you're getting deltas between 7, 6, 8, 9, all along here. But the inFoods data if you look, the treatment delta, we're getting approaching 10 and 15%, which is effectively better than all of these drugs that we have here. The other thing that I'll bring in mind is the inFoods, and I'll get into it in a second. It allows you to have a specific etiology for why the patient's having symptoms. And why is that important? Because you may be just giving these medications to mask what the patient's actually having. I'll give you an example. Let's say they're having lactose, and the lactose is giving them diarrhea. Well, you give them an antidiarrheal. So yes, they are on lifelong antidiarrheals, but we really should have advised them to avoid the milk products. It's a very simple example, obviously. So as I said before, the inFoods data, the overall response, which is the greater than 30% response, is 58 to 48% in terms of reduction. Excuse me, 58%, but 48% placebo, which results between 10 and 15% improvement, whether it's women only or men and women. And we know a large percentage of these patients are women. So let's go over some of the data. So this is where, when I initially looked at this, I was quite impressed. We had 90 commonly consumed foods on the first round that they looked at. They looked and tested, and I'll get into the next slide to help understand this better, all the foods with IBS and non-IBS related SARA, and that was checked with non-parametric statistics to see which foods increase IgG in response to IBS patients. And what we were able to do with that is after that did repeat testing to whittle it down to 18 foods. So oftentimes patients, when they come in, they say, well, doc, well, what are you going to test? Well, what does this test entail? And giving you these data pieces of how this is important will take you to why we didn't test for kombucha extract. So inFoods IBS technology. So food A was included on the panel. Food B was not. Why? And let me show you how. This Gaussian distribution basically allows us to put a 95th percentile control cutoff here for non-IBS patients, meaning these are patients that do not have symptoms. And even though there are some outliers here, with this cutoff, we were able to say if you are above this IgG level of signal, you are in fact in this range of being abnormal. So this is IBS patients. These are the distribution of IBS patients. But you can imagine if these are found commonly in most people, then these numbers may be a confounding variable. So you want to get these numbers of patients, and this would be considered a positive. Alternatively, for the kombucha extract, by the way, they didn't test for kombucha extract, I'm just making it up. This distribution of signal is a weak distribution. It is not where they can get an identifiable cutoff such that these patients would be identified, or rather these patients over here would be able to identified well as being positive for this food. This study was done at the Mayo Clinic, Harvard University, Michigan, University of Texas, Houston, 8 weeks, prospective, double-blinded, placebo. It's like somebody wanted to do a perfect study. It's kind of crazy. Placebo-controlled, randomized, multi-site. I don't know if we could put any more adjectives to make it sound better. And the arm, so we had the right patients. So we had the right distribution, female to male. Median age is a little bit young here, 41, but the 93.4 mean number of months treated for IBS prior to enrollment. So these are patients who came into the study with years and years and years in study of symptoms. So it's not that we just started having IBS symptoms yesterday. And this is the design of the study. So like I said before, randomized, double-blinded, placebo-controlled. Then they say, let's say the patient had a sensitivity on the test to blueberries and almonds. Then in the treatment arm, what we were able to do is we eliminated blueberries and almonds. And then what's important, and I love this, is that in the same amount in the placebo arm, they eliminated other things that were known to be negative for the patient. And they would find something that's kind of in the consumption of the patient. So eliminate things that in the similar quantity. So these they eliminated and these eliminated to be able to do the study. And they reached like awesome significance. So the p-value of 0.007 for global assessment relief and for global improvement scale of 0.04. So they hit their endpoints for which the FDA looked at it. They've been privileged to, it's going to be upcoming in a journal, not yet to be announced. They're going to be in a big journal. They also got the ACG Presidential Award for this study that they did, and this is the poster that was submitted. As I mentioned before, you had a reduction in abdominal pain intensity, as well as a reduction in bloating. And I want to review briefly the ordering process and a little bit of what the results are. So whenever I listen to these lectures, I think to myself, okay, do I think this data is worth something or not worth something? And if the study design is good, then even if it's a good design, do I think this will actually impact my patients? And then I think, okay, if it impacts my patients, how can I implement it? And I think about, if I implement it, how can I speak to my patients about it? As you're probably aware, this is not covered by insurance, it's paid out of pocket. So you're like, okay, now I have my patients who are complaining about my copay and this, that, and the other, or indigent patients or other patients, and like, how am I going to fit this into my practice where it's a tool that's actually effective and something where the patient comes back to me and say, hey doc, thank you so much for doing that test for me. So we'll go over some of those specific questions, which is where I think the bulk of what this information should be kind of focused on. So it's a blood test that takes about a drop of blood. You can do it in the office, or there are at-home take-home kits as well, which we can mail to the patient. It takes less than a minute to do. It's mailed to either you, the patient, or both. And if I initially started having it sent to me alone, and then I changed my practice to have it go to the patient and to me. Why? Because there's a lot of information that's really, really useful for the patient. And I'll go into that in the next slide. So again, this is based on the testing that we've done. It's really, really effective in terms of once we eliminate it, the patients get better. So the physician orders the test. There's a pay code that you have with the patient's due. And again, I'll get into that in 1 second. The sample is drawn, and then the report can be delivered by fax, by email, by portal to your practice as well as the patient, or to just the patient, however you prefer. So I'll leave this up for you to peruse as I talk about what I do in my practice. In my practice, actually, you know what? I'll go through this, and then at the end, after the cases, I'll tell you what I do in my practice. So this is typical of what you will get in your inbox as a result for the patient, and it's included with these pages. Now, this result, as you can see here, we're testing for orange, for honey. I know some of these are a little esoteric, but corn, oat, rye, wheat, cow's milk, pineapple, soybean, lemon, grapefruit, whole egg. So a lot of these, they're not typical of what you see on other tests. And one thing I want to point out is that these tests aren't like typical tests in the sense of when you go and you get an allergy test somewhere, they haven't done a controlled trial to see the level of IgG in a normal population versus IBS population, and then create a statistically significant greater than 95 percentile, meaning being a positivity over that. It's just a blanket number that they have that hasn't been tried in a placebo double-blinded controlled trial. And that's really, really important. Why? Because when you go to an allergy test or a patient comes to you, you're like, yes, you have an IgG response to that. And maybe if you eliminate that food, the IgG response will go down. But the likelihood that that positivity and IgG response is related to a symptom, you won't know and I won't know. But at least in this test, what we have with inFoods is that it will tell you specifically, yes, there's a high likelihood that you have some relationship between your symptoms and this positivity of test. Typically, you'll have what this shows, which is about 2 things or 3 things or maybe 1 thing that comes back positive. I actually had a patient that had like 5 or 6, which was interesting, and I'll get into that in a second. Oh, I covered black tea, sorry. For those people who like black tea, maybe it's black tea. This is where the rubber meets the road in terms of patient satisfaction, patient education, less phone calls to your office, and honestly, an improvement in your patient's outcome after you discuss the results with them. And why is that? Because not only are we telling them that it's orange here and showing them a glass of orange juice and putting them pictures of oranges here so they shouldn't forget it's oranges, I guess, but we're going through the specifics of what foods can contain this that maybe you haven't thought of. I mean, I'm sure I'm not alone in trying to explain to patients that milkshakes have milk. Well, maybe not milkshakes, but other foods that have other milk products in them, and patients don't realize when they have lactose insufficiency. So the other thing is that it goes through all of the little, as I mentioned, it goes through the different items that can contain this, and it goes through it for each one of the different foods that are there. And oftentimes, as I have faced, the patients want something in their hand that they can hold because, I mean, let alone just lecture that I'm going through with you now, which I'm throwing loads of information out. When the patients go home, they just say, oh, the doctor just said oranges. And then they don't really think about the other things that are either containing oranges or might have oranges, or they go out or they go to see the uncle or brother. So at least this will give them something that they can discuss with their family and have an educated and informed decision of how they're going to change their diet moving forward. So case studies. I've had a couple of patients that when they were doing this, first one was a 30-year-old Hispanic female. She came to me, she'd had multiple diets that we were trying. And I first thought that is because she was rotating diets, that might be the aegis of her complaints. But then I realized that she was doing things correctly. She had appropriately eliminated, if you will, lactose. She really didn't want to go through endoscopy. And I'm going to dovetail what I wanted to say at the end right here with the patient. The difficulty or the space where you can fit this into the conversation can be a myriad of options. One, in the patient who kind of wants everything done, you can give them, hey, we'll do endoscopy, we'll do small bowel biopsy. If they have diarrhea, we can do stool testing, we can check for EPI, we can do this, we can do this. And then also, by the way, this is a test that isn't covered, but can check for multiple things that may be in your diet that can be contributing to your symptoms. So it's not only that you could have a pathology, but you may have a contributing factor as well, which would be one of these. I find honestly that sometimes with patients, especially if they have deductibles for endoscopies and other things, because I have different patients, both indigent and non-indigent, that I allow them the choice to say, you can do an endoscopy, which involves a day off from work, anesthesia, somebody pick you up, somebody take you home, or, and this is only if I've really kind of eliminated other things, I'll say, or there's a test we can do ahead of time, especially my younger population, they really like this. They say, okay, you can look at things and see food that potentially can cause me this. And if that's negative, then I'll do the endoscopy, because some people don't want to jump to a procedure. They want to understand, hey, it makes sense to me that I'm eating things and it's making me sick. So try and look for something that I'm eating. Don't just go biopsy for H. pylori or biopsy my small bowel. Like, I don't want you to do a procedure to me. So you can give it all up front. You can give it kind of a la carte, whether it's cost conscious offering, or you can give it, I've done my endoscopy, I've done my biopsy, I've done stool testing, I've done breath test, I've done a trial of pancreatic enzyme, I've done. By the way, there's this other test that we haven't done. You've been with me for 2 months, 3 months, 3 years, 2 years. We can't put our finger on it. And we've all had those patients in our practice where like we keep juggling, they keep coming in every 2 months, every 3 months, and we wonder like, hey, are they just like doing something with a non-fermentable thing and they're re-kicking up their something? No, it's possible it could be one of these things. And maybe this is negative too. You always want to create expectation up front and understanding of what we're going to do. We have these tests, you can give them this sample, we can give you a test. These are the things we're going to test for, and then we'll come back. So that, getting back to that 30-year-old I was talking about. 30-year-old Hispanic female came in, had tried this, had tried that, and I offered it to her because we had done endoscopy in the past. I didn't see any abnormalities. I said, I don't think that we need to do another endoscopy. I have this test. It's available. It's around $150, depending on what the prices are at that time. It may change. $150. Is this something you'd be interested in? Be like, yeah. Now, this is one of my very first patients. I get the results back. I look at it. Pineapple. Pineapple. Who eats like pineapple? It's like, okay, maybe she's having pineapple every now and then. Maybe, I don't know. So she comes in. I'm all eager because this is one of my first patients. I'm like, hey, you know what? It came back positive. I just want to discuss with you. Let me ask you a question. Do you eat pineapple? I don't know if you speak Spanish. She said, me encanta piña. Me encanta. I was like, what? I was like, I eat pineapple every single day. I was like, are you kidding me? I like showed her the paper. I was like, this is pineapple. You're allergic to pineapple. You're having an increase in something because you're eating pineapple. She stopped it. Symptoms went completely away. It's like, what tests do we have that allow us to see pineapple as an etiology? Nothing. Like, where are we going to find? We're going to give Xifaxan. We're going to give simethicone. We're going to go through so many things. And this, by the way, is that patient I gave an example. She was having symptoms and symptoms and symptoms and going through and symptoms and symptoms. And so this is like, it was fantastic. It was a godsend for her. Then I had my other patient, who is one of these, I want to know it all. I want to hear it all. I want to understand it all. And so she jumped into it right away. Fortunately, unfortunately, she had like 6 things positive. And that's where it gets interesting and the art of medicine takes place, because the question becomes, well, how do you tackle this? Now, as you saw in the distribution, just because you're positive, it doesn't necessarily mean that that is exactly what is or isn't causing it. And it's really a stylistic thing. And I want to make it as plausible of a positive outcome as possible. So I tell the patients the following. I say, listen, you have these 6 things. I want you to pick 2 groups of 3. You're going to do 2 weeks off of these 3, and then you're going to do 2 weeks off of these 3. And you tell me which one feels better and feels worse. And then what I tell them to do is, like the FODMAP diet, I say, okay, of these 3, if you want to, we can try, meaning let's say one group of 3 gets her to feel better. Let's try and introduce 1 or 2 of the other ones, but we're going to do it like this. Like, let's say the first 3, corn, oat, and rye. So I say, okay, you have corn, oat, and rye. I want you to eliminate them. Oh, you felt better with that? Okay, let's take corn, oat, and rye. Let's take rye. I want you to eat rye once today. I want you to have 2 servings tomorrow, and I want to have 3 servings a day after that. And you tell me whether or not you're having a kick up in your symptoms or not. And then you can try it with the oat, and you can try it with the corn, and maybe you can whittle it down. It may be that she has 2 of them or 3 of them or all 3 positive symptoms. It doesn't matter. Okay, but you're trying and you're engaging the patient. They already see an improvement, and they're going to interact with you and be very grateful for this potential solution. So I think I probably talked really fast, but that's okay. I'm going to turn it over to Zach and the team, and then obviously if there are any questions, I'm happy to answer whatever I can.
Great. Again, if you guys could just go ahead and chat or Q&A any questions you have, that would be fantastic.
Sure. So are you talking to us? I think, Zach?
Yeah, I'm
Okay.
talking to
So-
the whole crowd.
Okay, cool. So the one thing I'll bring up again, because I think it's really important, the interplay of where you position this for your patients really comes from an understanding of what do you want them to get out of it, when do you want to mention it, how do you bring it up? Because most patients, honestly, they don't want to pay for something, but there will be a moment where you're trying to give value over just doing a procedure or just trying something that may or may not work. So it's definitely not the absolute first thing I think of, but after the first thing, it can be the second thing I think of. It can be the third, the fourth, the fifth, but it's definitely an interplay of what I want the patient to get out of it, when do I want them to get the information, and how I think it'll be in conjunction with other things. So I'll often see the patient, give them some solace of, hey, try this for now. We're going to wait for these tests, and when they come back, you tell me how that treatment worked, and we're going to go over your results collectively.
Great. We're just waiting for some questions. I think we'll have some here in a second. Sometimes it's a
Sure.
little bit of a delay.
It's okay, no problem.
Either that or you did such a good job that no one has any questions and they're ready they're ready to go.
Well, I will tell you, like when I listen to these lectures or people give talks, I'm either going to believe what you're telling me or I'm not. And if I believe it, then I want to say, okay, well, if this is going to work, then how can I use it? And I think I'm trying to address as best I can the how to. Because listen, there are lots of products on the market. Some are gimmicky, some are not. The data on this was outstanding. So if the data is good, give it a shot. Try it on 2-3 patients. It's going to help you. I'm telling you.
So I actually am an IBS patient myself, and I was wondering if I were to follow this diet, how fast can I expect to feel the difference in my symptoms?
So typically patients within the first 2 weeks should have it, but it can be as soon as a few days. It really depends on the level of reaction that your body is having to it. It's like any allergy inducing or IgG inducing mechanism. It really depends on the degree of sensitivity your body has. We know through celiac disease and other things that the antibodies, as you avoid the diets, the antibodies go down. So if you're having something that's causing an allergy or a symptom, then it's the quicker, the better, the more you eliminate, the better off you'll be. I have had patients with lactase deficiency that I honestly have to see 4 or 5 times in a row, and they swear up and down, I'm not. And I'll have a cousin in the room saying, oh, he had an empanada. The empanada had some cheese in it. And so it's like, it's definitely a work in progress with the patient, but it gives them hope that there'll be some outcome that'll be kind of a solve instead of kind of just a mild improvement.
Oh, and here we have some questions. Hold on one second here. Oh, okay. That's the same question. Okay, good.
I believe we have another question coming in as the user's typing it right now.
Yep.
Okay. Dot, 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 dot.
Dr. Shaikh, was this pretty easy to implement in your practice? I mean, was that something that was
Fantastic. The
yeah.
team that you guys have, they'll walk hand in hand with you. They'll bring the reports to help you draw the blood. They'll be there with your MA. They'll get you started because there is a portal and things you have to log in to put the information. But after the first, I'd say 3 or 4, it'll be fantastic. Firstly, secondly, if you have a mid-level provider, you can have them book the appointment under the aegis of having symptoms, and then at the end of that appointment, have them have the infood test. What I do is I'll book the infood test towards the end of my day so that we're not as busy. And then the little extra time that it takes for us to draw the sample, that's kind of built in with the fact that, okay, these are at the end of the day, we're going to draw the samples, we're going to send it out. So it's very easy to get started. If you can put it in a way where it doesn't disrupt your schedule or take up much of your time, then it's really, really effective to be done that way. I tried doing it in the day, and unfortunately, between one thing or the other, it took a little bit more time than I was comfortable in terms of time and space utilization. And now doing it at the end of the day, especially with the extended practitioners, it works really well.
There's another question, Dr. Shaikh. So how many patients did you use inFoods with and get positive results before you started offering it more frequently?
That pineapple was it. When I got a pineapple, I swear, come on. How am I ever going to guess pineapple? Like, I don't like, and I wouldn't even know to ask. Like, so I ask when I see my patients, I ask about kombucha, I ask about the caffeinated drinks, I ask about supplements like weightlifting supplements, I ask about herbs. I literally make a joke of it. Like, did you get something from your neighbor that you just take because she says, oh, this will help? I would never get pineapple. No question I have in my armamentarium would ever have got me pineapple. So after I got pineapple, I was like, whoa, maybe this is something. And then I got another one, and then another one, and then another one, and another one. I mean, I've had at least 15, 20 patients that like do fantastic with this. And that's just where I got it from week 1 to week 3. So I went from ordering 1 to ordering like 3 to now I order at least half a dozen every week, if not more.
At this point of using inFoods IBS in your practice, where do you use inFoods IBS in the treatment cycle of a patient? Do you use it in the very beginning prior to prescribing drugs, or do you use it after? Like, where do you use this?
So that's a great question. So it depends. So you have the driver for this for me is typically I have bloating, I have abdominal discomfort, typically. But I have some diarrhea slash constipation patients, not really constipation, but diarrhea, where I think that if I'm offering what I feel should offer some relief, whether it's medication or diet, and it's really not improving, then I'll offer it as kind of a secondary. But if patients have gone through a lot of the battery of medications through their primary or other gastros or what have you, and they're really not getting better, I really look to see, well, what's the patient looking for? Is the patient looking for a quick fix? Like, should I try and give them a course of Xifaxan, or are they looking to understand and try and eliminate, and they're really vested in the process of trying to not take too many more steps, but be effective with what their steps are? And that's because it's a financial thing too. So I'll offer them to, I make it, I make it a menu, and I say, I don't make the choices, I make the menu. These are the things you can do. This is what I think will help. This will also add. If you like that, we can do that. You let me know what you want. If you don't want to do it now, you can do it later. It's almost like a sales pitch. Sounds weird, but you could say, like, these are, I think it's important to position these things, whether it's this or other tests, in a way of, if we don't get a response with what we're doing now, we can try this later. And that way they have hope, like, okay, I'll do this, and if not, then I'll come back and I'll try that. And that could be either way. You could do inFoods first and then do the endoscopy, or you could do the endoscopy, then do inFoods, or things like that.
So depending on what the patient wants, really.
Correct.
Yeah. Okay. One more question. We're at the right at the half hour mark, and so just for everyone's time, we'll take one more. It's just typing.
And I think Dr. Ronald Levy is trying to join us right now as well.
Levy.
Still typing. It's a big question.
It's a long question.
I think there's a question where was this presented at the DDW? This was presented in by University of Michigan in the IBS clinical session at the 2024 DDW, in the IBS clinical session as a new technology. I was there. It was well received. There was 5 mentions in other presentations that happened at the DDW after that presentation was given. So I think it was there was quite a bit of interest at that time. Still typing.
Sometimes when people just type in 2 letters, they forget that it's there, and it keeps bubbling like that. We can get back.
Oh,
Oh, here
go.
it is. Yeah.
It says, do you offer inFoods to every IBS patient? My concern of offering to patient is if they can't afford it. Although some of the prescription options are costly even after insurance, would food treatment possibly be more cost effective long term for a lower income population?
So I see a fair, that's a great question. Thank you so much. I see a fair amount of patients where I have to take cost into consideration. And I find that the $150 mark is such that it's manageable for them. But to get to more of what your question is, the prescription often the prescription options, if they're effective and covered by insurance, then I will try those first. I won't jump to inFoods unless I think that it offers a more useful tool to the patient. What I mean by that is if you're having godforsaken bloating and you've done what I've asked you in terms of the diet and we've done whatever indication with breath testing or other things, because those aren't without cost either, I try and see where I think that this may fit for the patient to kind of make, like, again, that educated choice to, it's weird, but to invest in their health. Like, we try and do everything possible to minimize costs, but especially in the beginning of the year, we're in November right now, or excuse me, October right now. And in a couple of months, everybody's deductible is going to reset. When the deductible resets, they're not going to want to do this. I don't want to do that. I want to do this. And lab testing, especially if you go for that battery of testing on your arm, that costs between $700 and $800 if you go to the allergist. It's a lot of money. So I don't think that it's appropriate to offer to every patient. I'll say it again. I don't think it's appropriate to offer to every patient, but I do think after a concerted history and evaluation of what the patients are complaining of, if you've addressed in your best ability the specifics of that and still not really responding, then I think that it's worthwhile offering them a choice. I mean, oftentimes if you listen to irritable bowel syndrome and bloating lectures, they'll tell you that we can't figure out what it is, and you should educate the patients from the beginning that we can't make it go away, but we can improve it. And that's really just blowing the smoke away from the flames. So I look at it as, can I help them feel symptomatically better with an option that can be covered by insurance? If they have the means and or the desire, then I would like to explore other options that can potentially help you. I don't think that avoiding foods will be a cost burden, unless I misunderstood the last portion of it. But avoiding foods will help them kind of eliminate what they may or may not be being afflicted by. So I think that from a cost standpoint, it's very patient specific, and I don't think in the long run it'll increase the burden. But to your point, if it shows nothing and they still have symptoms, yes, so then increase their burden. But the NNT is pretty low. Like, to get this to be effective is pretty good. I mean, you're talking, if you look at the data, it's 10 to 15% delta. And even the best things like Xifaxan don't have the numbers that are equivalent to this finding an etiology for the symptomatology. So it makes sense to offer this as is more effective for like the IBS-C or the IBS-D drugs. Not to mention there's no real IBS mixed treatment, which this would give you a mixed treatment response.
This is this is kind of a follow-up to that question. I think you can see it here. Would treating with inFoods be more cost-effective than the cyclical usage of pharmaceuticals where you're paying monthly and a monthly copay?
Absolutely. That makes complete sense. So I'll give you my pineapple patient. My pineapple patient has gone through a myriad of tests, a myriad of medications, has had multiple doctor's visits, and now she hasn't seen me. I mean, maybe I shouldn't do inFoods because I'll get more visits from the patients. But so I think I think it's unfair to say, hey, if this is expensive, I shouldn't do it. And I know nobody's saying that, but I think it's fair to say that if you can get a response, then the value is there. If you can find a result that helps your patient feel better, then the value is definitely there. But there's no way for you to know without doing it. And the data shows that it is effective. So if the data shows it's effective and the value is there for the patients that get a positive result, then it's just like doing endoscopy and colonoscopy. If you do endoscopy because the patient has epigastric pain, what do you find? A mild gastritis? How many endoscopies do we do? And the endoscopy is uncovered. It's not a screening procedure. So I think there's definitely a way for it to be more effective than the cyclical usage of pharmaceuticals, which is what your question was.
Well, everyone, thank you. Thank you for joining. And Dr. Shaikh, thank you for this. We really appreciate it. If you do have any other questions, please don't hesitate to contact us directly. We'd love to forward any questions that you do have. If Dr. Shaikh has some time to answer them, if you do have some left over, there's one question still coming in. We'll wait 2 more minutes. Is that okay, Dr. Shaikh?
Sure, no problem.
Okay.
As long as they don't ask me what she substituted the pineapple for, because I don't know. You need to put a new option where you can put voice type.
Oh, it was just a great job, Dr. Shaikh. Well, thank you. Thanks, everyone.
All right.
Dr. Shaikh, thank you
everybody.
again. We appreciate it.
Thank you. Bye-bye.
My pleasure.
Bye-bye.
Thank you very much.